How do you triage shortness of breath in patients receiving immune checkpoint inhibitors? And what are the special considerations for patients with lung cancer? Patients often report shortness of breath or dyspnea on exertion. There is an increased likelihood that this might be present in patients with lung cancer at their first diagnosis, and this actually may be what brings somebody to diagnosis initially. But it becomes particularly challenging for patients that already have underlying shortness of breath, as that there is not really a barometer to measure level of dyspnea, so you've got to use some other tools. It's important to explore other etiologies of shortness of breath before assuming that it's due to an immune checkpoint inhibitor. Shortness of breath may be due to progression of disease, lymphangitic spread of disease, pulmonary embolus, pleural effusion, pneumonia, pulmonary fibrosis, COPD exacerbation, anemia, cardiac dysfunction, abdominal ascites, generalized weakness, or pneumonitis due to immune checkpoint inhibitor. So important to rule out all of those other causes, as the treatment of each is going to be very different. Evaluation of the etiology of the shortness of breath is imperative to drive management. For instance, the management of pneumonia will be different than the management of immune-mediated pneumonitis. And in some cases, patients may have overlapping complications that require independent management. If a patient has a pneumonitis from an immune checkpoint inhibitor, it actually may trigger an exacerbation of COPD, or it may compromise the patient's pulmonary status enough where they also develop a secondary pneumonia. So a thorough history of patients' symptoms is very important. Chest X-ray may be your first screening tool, but a CT scan with sequencing is going to be important to really evaluate the etiology of any chest abnormality, such as potential pneumonitis. In some cases, patients may also require a bronchoscopy and pulmonary function tests. Management, again, is going to be based on determining the final etiology. But in the least, patients should be administered supportive care, such as oxygen support, perhaps nebulizer treatments if that's so indicated, and pain management if needed. If indeed pneumonitis is diagnosed, patients will require steroid bolus, and that's 1 to 2 milligrams per day of corticosteroid, and that's administered until stabilized to a grade 1 or less, and then tapered over at least a 1-month period of time.